Okay, class 5 antiarrhythmics. This is kind of like your mixed bag of a few different things. So let's start off here with adenosine. This is probably, the one I talk about the most here. Adenosine, it's super short acting, so it acts really quickly. And when you give adenosine, immediately patients will say they have the sense of impending doom. They just feel like they're, dropped from a 40-story building, and you kind of have to warn people before you give it. But for board exams, they're not really going to test you so much on that. Sometimes they'll say a drug was given and the patient had this sense of impending doom, or they had flushing, or they even had chest pain after they were given the drug for a short period of time, for like 10 to 15 seconds. And the idea here is what adenosine does is it inhibits these L-type calcium channels, the same L-type calcium channels we talked about when we talked about calcium channel blockers. And these, you can imagine, will give kind of similar effects to what we saw when we gave a patient calcium channel blockers. So going back to our little diagram here, again, beta blockers, right? We know these are going to decrease CAMP, okay? And they're going to decrease calcium levels eventually in both the pacemaker cells, which we already talked about, which is going to be responsible for decreasing the heart rate, okay? And they'll also have effects in the ventricular cells, which will decrease contractility. What adenosine does is adenosine is going to work by doing something similar. It's actually going to inhibit CAMP, just like beta blockers. So adenosine is going to kind of have that same effect. It's going to inhibit CAMP, but it's going to do it through the GI pathway. Remember, beta blockers are blocking the GS pathway. So beta blockers are inhibiting, I'm going to put in a negative sign here, inhibiting the GS pathway. But adenosine is actually stimulating the inhibitory pathway. Okay, so it's kind of just a play on words here, but adenosine is stimulating the inhibitory pathway. That's going to cause lower levels of CAMP, and so you're going to get this same effect here at the pacemaker cells. It's primarily going to have a very significant effect here at the AV node. So it's going to kind of slow things down. It's going to slow this calcium current down by using this GI inhibitory pathway, inhibiting levels of CAMP, right? Lowering levels of CAMP, I should say, lowering calcium levels in the AV node, and that's going to cause you to have a prolonging at this PR interval temporarily. You're blocking conductivity through there. So essentially, in one way, you can think of the effects at the pacemaker cells similar to beta blockers. It's just really short acting. And a lot of times in real life, we give adenosine, the major disease you want to remember it for, especially when you go on to step 2, is going to be supraventricular tachycardia. Okay, when you give adenosine and you have a patient that's in SVT and their heart's beating really fast, you give adenosine and immediately you'll see the heart rate kind of start to come down. That's your way of knowing that it's probably supraventricular tachycardia. And I'll give you way more details on that when we get to the step 2 lectures. But again, going back to my point initially, you just have to know the mechanism. You know the mechanism, you'll get the questions right in terms of what's happening, because nothing's changing, right? We're just focusing on one part of the pathway. We're inhibiting that part of the pathway, and then we're able to see, yeah, if I inhibit the L-type calcium channels, these are responsible for depolarization, and they get activated in the midway through phase 4. So you get a prolonging of phase 4, and you're going to get some phase 0 prolongation and depolarization as well. Now, the last thing I want to say about adenosine, just pro tip here, the effects of adenosine can be attenuated or kind of inhibited in some way if the patient is taking a lot of caffeine, or if they're getting theophylline, which is kind of an old school drug but comes up in board questions in this particular scenario. So if the patient is getting theophylline or they're having a lot of caffeine, the effects of adenosine won't be as great, because those two actually can act as an antagonist to the adenosine receptor. Okay, so just something to keep in mind. All right, digoxin on here. The mechanism of digoxin, I'm not going to go into too much detail here. We're going to have a whole video on this. I just want to kind of hit this really quick, but digoxin inhibits the sodium-potassium ATPase. This indirectly leads to really high levels of intracellular calcium. So it has to do with the fact that your sodium, instead of it getting pumped out, it's ending up staying in the cell, and that sodium in the cell then causes more calcium to come in the cell through calcium exchangers, which eventually causes your intracellular calcium to go up. So indirect increase in intracellular calcium. I'll show you that whole mechanism of action in the pharm section. But the big side effect to remember here, and there's many with digoxin, but the big one that they usually put that calls you to thinking about digoxin is this blurry, particularly yellow discoloration to the vision. That's very classic for digoxin. Now, digoxin has really 2 major effects. The first major effect of digoxin, so number 1, is that it has parasympathetic effects. So it's going to have vagal tone, right? So it's going to slow things down. It's going to slow down the heart rate. So that's where some of these antiarrhythmic effects come in. But the other thing is, I just told you, it increases intracellular calcium, particularly in ventricular myocytes, not in pacemaker cells as much. Okay, so it's mostly in ventricular myocytes, which means that increases in contractility, calcium-induced calcium release. Okay, if I had high calcium levels in pacemaker cells, I might actually have faster heart rates because the calcium, the L-type calcium channels, are responsible for depolarization, right? But in ventricular myocytes, the sodium channel is responsible for depolarization. When I have high calcium in pacemaker cells, think high heart rate. When I have high calcium in ventricular myocytes, think about high contractility. And the reverse is true. Low calcium in pacemaker cells, look at what we've been doing this whole time. Low calcium in pacemaker cells, low heart rate, if you can read that. Low calcium in ventricular myocytes, low contractility. Okay, so again, associate the calcium with the cell you're talking about. Digoxin is tricky because it causes slow heart rates on pacemaker cells, but it causes increased contractility via increased levels of calcium in ventricular myocytes. So don't get fooled by that. Okay, magnesium. Like we said, classic use here. It's used to treat torsades. It can also be used for digoxin toxicity, but the big one I would remember is definitely torsades. It can cause decreases in intracellular calcium, which is why it can be used to treat digoxin toxicity. And this can also make some sense as to why it's used to treat torsades, right? Decreases in intracellular calcium. You're slowing down pacemaker potential. Ivermectin here inhibits the slow funny channels. Again, can prolong phase 4. Okay, and this is going to have also an adverse effect that's similar to digoxin, so I don't want you to get these two confused. This one kind of comes up as really bright vision, so a visual luminous phenomena is classic for ivermectin toxicity.